السلام عليكم ورحمة الله وبركاته. I am Professor Abdulazim Al-Hifni, Professor of Internal Medicine, Rheumatology and Immunology at Shams University. My lecture today is about rheumatoid arthritis. It will be divided into 4 to 5 parts. This is the first part. Intended learning outcomes. By the end of this lecture, you should be able to define rheumatoid arthritis and its pathogenesis, interpret patient symptoms and signs to reach diagnosis as early as possible, enumerate 2010 rheumatoid arthritis classification criteria, choose the most specific investigations and tools for follow-up, suspect patient prognosis, complications, and causes of mortality, if any, in this patient, select appropriate lines of RA treatment for specific patient, identify the proper time to refer the patient to the rheumatologist. Now, what is rheumatoid arthritis and its epidemiology? Rheumatoid arthritis is a chronic systemic inflammatory disease of unknown etiology associated with HLA-DR. The occurrence of RA in identical twins is reported to be from 15 to 30%. It starts at any age but peaks at the age of 30 to 50 years. The prevalence is about 1% worldwide, and it is lowest in Black, African, and Chinese, and the highest prevalence in Bima Indians. The female to male ratio is about 3 to 1. Primarily, rheumatoid arthritis affects the peripheral joints in symmetric distribution with exacerbation and remission. It has variable extra-articular features, as we will know later, and constitutional symptoms. In most cases, RA is a chronic progressive disease that, if left untreated, can cause joint damage and disability with increased morbidity and mortality. Pathogenesis of RA. The next video will explain this pathogenesis, and if you have any inquiry, please don't hesitate to contact me in the face-to-face session.
Joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1 and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs, or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage. As we have seen, TNF-alpha plays a key role in the complex pathology of RA. One cyto.
Banus. The inflammatory granulation tissue, which is called banus, spreads over and under the articular cartilage, which is progressively eroded and then destroyed. Maturation of osteoclasts in the synovial membrane and in adjacent bone combine to erode bony structures, as we see in the previous video. Later, fibrous or bony ankles may occur. Muscles adjacent to inflamed joints atrophy and may be infiltrated by lymphocytes. This collectively leads to progressive biomechanical dysfunction and may further amplify destruction of the joint. This is a healthy joint, which is a meeting of two long bones, each one covered by a cartilage, which is a very tough and smooth layer that permits articulation smoothly, and covered from outside by the capsule, which is lined internally by the synovial membrane, which is very thin, one or two layers only. While in rheumatoid joint, the banus formation with its thickened inflamed synovial membrane will erode the cartilage and the underlying bone, causing destruction of this joint and cartilage loss. And also there will be synovial fluid increased in amount and containing activated immune cells, leading to the inflammation and with its swelling and warmth and difficulty in movement of this rheumatoid joint. This is the end of the first part of this lecture, and we will soon deliver the second part, and thank you.